It's a pleasure. I know that my colleagues in Egypt, also some other African countries, they are doing living transplantation. So I thought paired donation has already been done here, but I just learned that there's no paired donation activity in Egypt as well, which is something very important actually, because we are getting all these referrals, and when these patients are coming with their couples, almost half of them are refused because they are ABO incompatible or they are high sensitized patients. And right now, all guidelines are especially focusing on paired donation to pass through this gap and have them a healthy transplantation. In the United States, almost 12% of all living donor transplants are passing through the paired donation programs. Especially in countries, also in Turkey, in Egypt, it's very beneficial to have a paired program. It's not only cutting the costs, but it's having less infection and better graft survival. So it's vital for countries who are depending on living donor transplantation. The most important limitation of paired donation is the blood group O donors who have a non-O recipient. Just the contrary, sorry. So paired donation first started in South Korea. Several centers did this in particular countries. But then it started to have national registries. The pools get bigger and bigger. Talking about Netherlands, UK, Canada, and Australia. And USA is the most important country that's depending on paired donation. In United States, there's a federal government-funded program, a kidney paired donation program, but there are also independent multi-center alliances, and also there are some hospital-based programs like San Antonio program or Johns Hopkins program. So when we're talking about paired donation, the most easy is to just match the compatible pairs. One is A and B, the other is B and A. So you just share the organs at the same time during transplantation. What you can do better is you can start doing some chains. You can put some hypersensitized patients in those groups, or you can do, you can mix more patients and do triples or four transplants in a row. Then you can progress more and maybe you can start non-simultaneous transplantation. In Turkey, we are not doing non-simultaneous. Whatever we are doing is just happening at the same time. But in Europe, in Australia, Canada, and US, having it doing non-simultaneous gives you a bigger pool because you have the time to find better alternatives, better candidates. And you can start to have uncontrolled chains. That means you do it, but you don't know what will come next. And that recipient can wait for a long time to have a kidney in future. You can have a combination of desensitization and also ABO incompatible transplantation in your paired donation list. Like in Australia, in UK, they accept low titer ABO incompatible transplants, and they also match those couples in this regard. You can have your deceased donor program get involved with this paired donation program. And then it's national registries getting the pool bigger and bigger, so you get more patients. And you can, maybe in time, you can get international kidney paired donation. Maybe that will be what we're going to talk in future. So talking about closed loops, it's also the Dutch program mentioned the benefit to do triplets. While you are doing AB and BA transplants, it's very easy to put a high sensitized AA or a BB couple, and that gives you capability transplant those high sensitized patients as well. So the advantage of closed loop is you have no chance to have an orphaned recipient. So no matter what you plan, it's going to progress that way because you do all surgeries immediately at the same time. Talking about, again, the unbalanced kidney paired donation, a couple can come. For example, I am blood group A and my donor is blood group O, but you can still include them to your paired donation program and you can offer them a younger kidney. You can offer them a better HLA match. Or maybe the kidney has cysts or some other problems. You can even offer those things. And at that time, I may accept it. Or even I may accept it altruistically. Even if it's not to my benefit, I can accept someone else with blood group O to get transplanted. So this is a very important advantage to include those patients because, as you know, blood group O is the most important problem in paired donation. So you can have altruistically unbalanced pairs for transplantation. You can have, if you do ABO incompatible transplantation, you can also do paired donation in this regard. So the patients with high anti-B and anti-A antibodies, you can just flip them and at that time they can have a more safe transplantation by switching their donor. So here blood group O gets a B group kidney and its anti-B titer is less than 64, just like that. In paired donation, the most important contribution comes from the non-directed donors, it's the altruistic donors. It's very important. In Turkey, we have very rare altruistic donors. I don't know what's going on in Egypt. But in this situation, you can start a chain. So in Canadian paired donation program, it seems 61% of all incompatible paired donation pairs starts with an altruistic donor. And in UK, they are first offered to high sensitized patients, but if there's no match, then it goes to the paired donation program. So when you are doing so, to let you know that altruistic donors are donors that they just accept to give their organs to someone and they even don't see that recipient or just see the recipient during the surgery. So it's completely for giving a gift of life. So once this is happening, this chain can start and it can go to a cadaveric patient or it can just wait in a bridge donor and in time when they find another suitable couple, this chain can go on. Well, the integration between living and cadaveric program is not that trendy anymore because, of course, living and cadaveric transplantation has different graft survival rates. The quality of the kidney is not the same. But you can have a chain start with a cadaveric kidney and otherwise you can have a cadaveric kidney taken out from the system for a patient who really is matching to that kidney and that patient is very high sensitized. And at the end, the living donor can pay it back to either to cadaveric system or that can further progress as paired donation program. Well, here's the national kidney paired donation programs these are the most active ones. The Netherlands, UK, Canada, and Australia. They are all started in 2004 to 2010. And all these programs have a body supporting them from the government. And they have a dedicated central staff working for them. HLA laboratories are single in the Netherlands, but the other centers have multiple tissue typing labs. The accepting ABO incompatible donors are possible only in UK and Australia. And also this is another important issue, whether donor should travel or organ should transplant. So in Netherlands, the donor travels, but in Canada it can change, but in UK and Australia, the organ is transported. So they also make a match cycle in every 3 months, or in Canada it's every 4 months to say it. And they depend on virtual cross-match for making, evaluating the pairs. So talking about organization, for example, when talking about Netherlands, it's a small geographic area. So it's good to have single tissue typing lab. The transfer is not a problem. And also the transportation of the donor is not a problem. But, you know, talking about, for example, United States, a donor should go and reach to the other part of the United States and far from home. This is a big challenge. And they have shown that the kidneys are shipped safely, and this has positive influence on increasing the donation rate in paired donors. And for talking about match runs, some do it in 3 months, some do it 4 months, but actually the important thing is if you do it in a very short period of time, then you won't have enough pairs and you won't have a very successful result. And if you wait for a long time, then the patients are going to wait. But there are some new softwares, it seems that they are finding the optimal timing for running the match. And what about matching algorithms? So what we do in Turkey is we generally do it manually. But when you talk about a national registry, if it's getting bigger and bigger and you have more patients, then you need a computer program to make it run. At that time, these computer programs are generally using first accept protocol. It means in these programs, they just figure out the necessary requirements for accepting a kidney for that recipient, and whoever couple fills first, that gets the pair is planned according to that. So when you do it with your hands manually, you can find a better match. But when you start to use computer programs, it's generally to fix the requirement is enough. When you look at the whole series, maybe you can find a kidney that will bring better outcome. But as the pool gets bigger and you want to have more transplants, it's more to use the computers, and allocation is going that way. And in very big programs, even computer programs are not working, then you need the mathematical algorithms to solve which kidney can go to which area. So as the pool is increasing, the number of transplants are increasing, but there are some problems coming with the challenging of matching the kidneys. Just quickly to show you, so this is from 2008 to 2017. During 9 years' time, they did 2,037 consecutive living transplants from paired donation in United States. And here you can see that the patients with blood group O, they have waited with a mean time of 6 months. This is 0 to 37. And this is the most waiting time in this group. And this is very hard to see, but I can just memorize from here. When they evaluated the transplants that's done by paired donation compared to the other living donor transplants during this time period, they have seen that paired donation enabled significantly greater proportion of HLA immunized patients transplanted. So those patients that we couldn't be transplanting, that can have a better chance when we use paired donation programs. Also, The HLA mismatch pairs are also better in paired donation. So we can find better match when we do paired donation as well. So in these series, 11.7% had undergone a desensitization. This is either for high sensitization or ABO incompatibility. But this enables the very hard match recipients to find a kidney that wouldn't be capable to have transplanted in regular fashion. Just coming to the end, this is the issue about the international transplantation. This is also presented from United States, saying that when the chain has stopped, you can find another, you can invite someone from another country and you can just get the cost of it and have that couple transplanted to have a progress in your chain as well, which is got to be discussed in ethical issues as well. So just talking about what we are doing, Turkey is very red because we do mainly living donor transplants. This is the living donation scheme in Turkey. So we do 3,800 transplants per year. And just the country of Europe, because it's 20% living there and 20% is our cadaveric rate. So we mainly do living donor transplantation. This is our database starting from 2014 to 2019 September. We have done 732 patients within our kidney paired donor programs. These are mainly performed by single centers or aligned centers, and they are mainly performed as double transplants. Most of them are, 95% is double transplants. There's 1/5 and 1/7 pairs matched together, but the most of them are then the 3 pairs, which is 4%. Here we have death-censored graft survival, but patient survival 1 year is low, showing that maybe high immunized patients may have some bad outcome during that period. And this is especially from Turkish pairs, but 5% is from other nationalities, but mainly from Bulgaria, where we have some Turkish nations living in Bulgaria actually. And all those paired donation transplants are evaluated in our legislation system. So as a result, paired donation is a very important aspect, and it enables transplantation of high sensitized patients and ABO incompatible patients. I believe in time we will all have national registries and we will be able to do a better match in all around the world. Thank you very much.